Welcome back to the deep dive. Today we're taking a really close look at a fascinating area in musculoskeletal medicine, orthobiologics. It seems to be everywhere now.
It really does. It's a field that's certainly captured a lot of attention. And at its heart, orthobiologics is about using biological materials, often ones naturally found in your body, to try and, well, boost healing and regeneration in tissues like bone, cartilage, tendons.
Right, the musculoskeletal system. And these materials, they can be from the patient themselves. Autologous, is that the term?
That's one, yes. Autologous means from you. Or they can be allogeneic, meaning they come from another human donor.
Okay. And our aim today really is to unpack this whole area. We've got some great sources, recent reviews, even a curriculum outline for professionals.
Yes. And what these sources really highlight is this sort of tension. On one hand, you have this increasing popularity, this huge interest. But on the other, establishing really solid evidence-based guidelines is proving, well, quite difficult.
Why is that? Is it because the treatments themselves are so different?
That's a huge part of it. The term orthobiologics covers such a diverse range of materials and preparation methods. It's not like a single pill with a defined dose. So comparing studies, standardizing treatment, it's complex.
It feels like the underlying idea is incredibly appealing, though, moving beyond just managing symptoms to actually trying to heal the damaged tissue itself.
That's absolutely the goal. Targeting the root cause, stimulating repair rather than just masking pain. But, as you said, translating that promise into reliably effective, predictable treatments, well, that journey is proving quite intricate.
So let's start with the basics. What exactly falls under this umbrella term, orthobiologics? What are the main types we should know about?
Okay, good place to start. We can broadly divide them into two main categories, really based on the source material. First, you have the blood-based therapies.
Like PRP, that's the one most people have probably heard of.
Precisely. Platelet-rich plasma, or PRP, is the best known. And then you have some variations, sometimes called PRP-like products, things like autologous conditioned serum ACS or autologous protein solution APS. They all start with the patient's blood.
Okay, blood-based. What's the other main group?
The second major category involves tissues or cells. So this includes things like bone marrow aspirate concentrate or BMAC.
Right, from bone marrow.
Yes. And then microfragmented adipose tissue, MFET, which is derived from fat tissue. And then you get into more specific cell populations, perhaps the most talked about being mesenchymal stromal cells, or MSCs.
And getting hold of these materials, how is that done? Does it involve complicated procedures?
It varies quite a bit depending on the product. For PRP, the concept is fairly simple. You draw some blood from the patient, much like a standard blood test, and then you use a centrifuge.
To spin it down.
Exactly. To separate the components and concentrate the platelets. Platelets are packed with growth factors, which are key to the proposed mechanism.
Okay, and for the others, BMAC and MFAT.
BMAC requires aspirating bone marrow, usually from the iliac crest, the hip bone. That aspirate is then typically centrifuged as well to concentrate the nucleated cells. Right. Just include those MSCs amongst other cell types.
An MFAT from fat.
Yes. That usually involves a small liposuction procedure to harvest some fat tissue. This fat is then processed, essentially minced or washed, to create this microfragmented tissue that can be injected. It retains cells within their natural matrix to some extent.
So you're taking something the body already has, concentrating or processing it minimally, and putting it back where it's needed. What are they actually doing then, once injected? How are they supposed to help healing?
The mechanism of action. That's perhaps the most debated and researched area. The central idea is that these preparations are loaded with bioactive molecules, growth factors, cytokines, signaling molecules.
Biological messengers, essentially.
That's a good way to put it. Platelets in PRP, for instance, release a whole cocktail of potent growth factors when activated at the injury site. Things like PDGF, TGF-beta, VEGF, the list goes on.
And these factors trigger something.
They're thought to orchestrate a complex biological response. This includes potentially dampening down excessive inflammation, which can actually hinder repair if it goes on too long.
Okay, reducing that inflammation.
Yes, but also promoting the good stuff.
Yeah.
Stimulating local cells to multiply, proliferate, and perhaps change into the cell types needed for repair, like cartilage cells or tendon cells. That's differentiation.
Right.
They also encourage the growth of new blood vessels, angiogenesis, which is vital for bringing oxygen and nutrients to the healing tissue. Some components might even provide a temporary scaffold or directly interact with cell signaling pathways to guide the repair process.
So it's not just one thing, it's a whole local conversation stimulating repair.
Precisely, a complex interplay. And it's important to realize different orthobiologics contribute differently. PRP's main contribution is considered to be that burst of growth factors from the platelets, whereas BMS or MFAT contain a mixture of cells, including MSCs, which can also release factors, modulate the immune response, and potentially contribute more directly to tissue building, although the extent to which they truly differentiate in vivo is still debated.
And you mentioned PRP isn't technically cell therapy in the same way?
That's a key distinction made in the sources, yes. While platelets are cell fragments, PRP's action is primarily through the factors within those fragments. It's not usually classified alongside therapies, where the intent is to deliver a concentrated dose of viable cells like MSCs from bone marrow or fat.
That makes sense. And although using these for, say, arthritis or tendon injuries feels quite cutting edge, this idea of using the body's own materials isn't brand new, is it?
Not at all. The concept has roots going back decades. One of the reviews mentions the first documented clinical use of autologous PRP blood taken and given back to the same patient was actually in cardiac surgery, way back in 1987.
Really? Cardiac surgery?
Yes. So while the focus on joints and tendons has boomed more recently, the underlying principle isn't entirely novel. It's been evolving for quite some time.
Given that history and these really interesting potential mechanisms, you'd think the evidence base would be rock solid by now. But you said earlier establishing guidelines is tough. What's the reality of the research?
Ah, yes, moving from the theory to the clinical evidence. This is where things get, well, complicated. The single biggest challenge, echoed across all the sources, is the heterogeneity.
Meaning the variability.
Exactly.
Yeah.
Orthobiologics aren't standardized drugs. Take PRP. Its exact composition can vary massively depending on the patient's own biology, their age, health status, even recent activity levels.
Right.
Then add in variations in how the blood is collected, which commercial kit is used for processing, the centrifuge settings, the final volume, whether an activator is used. You end up with potentially very different products, all being called PRP.
So comparing study results is like comparing apples and, well, sometimes very different apples or maybe even pears.
That's a fair analogy. And this lack of standardization extends beyond just the product. Dosing isn't standardized, injection techniques vary, post-injection rehab protocols differ. It makes pooling data and drawing firm conclusions incredibly difficult.
And you mentioned even practitioners might lack standardized training.
Yes, the curriculum outline we looked at specifically points to a need for more comprehensive, standardized education. There's a knowledge gap, which can further contribute to inconsistent application and outcomes. All this variability inevitably impacts research quality.
Okay, so bearing that major caveat in mind, let's try to pick apart what the evidence does show. Starting with PRP again, as it's the most studied, where does it seem to stand?
Right, PRP certainly has the largest volume of research, especially for common things like knee osteoarthritis or KOA. Several meta-analysis studies that pool data from multiple trials do report positive findings for KOA. Improvements in patient-reported outcomes, things like pain scores and functional ability. For example, a well-known meta-analysis by Shen and colleagues looked at 14 randomized controlled trials, or RCTs, involving over 1,400 patients.
Okay.
They found that PRP injections led to statistically significant improvements in WAC, scores a standard measure for OA pain, stiffness, and function compared to control groups, at 3, 6, and even 12 months follow-up.
That sounds pretty positive, doesn't it? Significant improvements lasting up to a year.
On the surface, yes, it does sound encouraging. However, and this is a crucial however, the same meta-analysis performed a risk of bias assessment on those 14 trials.
Assessing the quality of the studies themselves.
Exactly. And they found that 10 out of the 14 RCTs were judged to have a high risk of bias. The other 4 were at moderate risk.
High risk of bias in most of the studies. What does that mean practically?
It means we have to be cautious about how much we trust the results. High risk of bias could stem from issues like inadequate blinding patients or assessors knowing who got which treatment, unclear methods for selecting patients, or inconsistent follow-up. These flaws can skew the results, potentially exaggerating the benefit.
So the overall signal might point towards a benefit for NEOA, but the foundations of that evidence aren't as solid as we'd ideally like, partly due to study quality and that variability in PRP itself.
That sums it up well. There's potential benefits suggested, but the evidence quality is a significant concern.
What about other common problems, like, say, tennis elbow lateral epicondylitis?
Yes, that's another area where PRP has been studied quite a bit. A systematic review and meta-analysis by NEMIC did report improvements in patient outcome scores that were considered clinically meaningful, meaning the average improvement was large enough for patients to actually notice a difference.
Okay, so potentially helpful there too.
Potentially. But again, caveats apply. That particular review highlighted major inconsistencies in the studies it included. Things like missing data on patient age or sex, or crucially, not specifying the exact PRP preparation used.
Ah, that standardization issue again.
Precisely. And importantly, that NEMIAC review didn't include a formal risk of bias assessment using standard tools. So while the results seem positive, it's harder to gauge the reliability without knowing the quality of the underlying studies.
It's a recurring pattern, isn't it? Promising signals, but hampered by inconsistency and questions about research quality. What about plantar fasciitis, that heel pain condition?
Indeed, a fairly recent meta-analysis from 2024 by Herber looked at 21 RCTs with over 1,300 patients. They found the PRP injections seemed more effective at reducing pain compared to several other common treatments: corticosteroids, shockwave therapy, and even placebo injections.
Better pain relief, that's significant.
It is. They also found better scores on a specific foot and ankle function scale, the AOFAS ankle hindfoot score, when comparing PRP to steroid injections and placebo.
So improvements in pain and function there.
Well, better scores on that specific functional scale, yes. But interestingly, the same analysis found no significant difference between PRP and the other groups when looking at objective measures, like the actual thickness of the plantar fascia measured on ultrasound, or when using a different functional score called the foot function index.
So pain relief seems better, but maybe not changing the underlying tissue thickness or overall foot function consistently.
That seems to be the implication. And echoing the findings in other areas, the authors explicitly noted significant variability in the PRP methods used across the trials and concluded that the overall quality of the included RCTs was low.
Low quality evidence again. It really underlines the challenge, doesn't it? Even where results look positive, like pain relief for plantar fasciitis, the confidence in that finding is weakened by the study quality.
Absolutely. It's a constant refrain in the literature.
What about less common applications? We hear about PRP being used for ligament tears, other tendon problems, even spine issues, or during meniscus surgery.
Yes, clinical practice has certainly expanded into these areas. But the sources suggest that strong evidence-based consensus statements or clear guidelines are generally lacking here. Meta-analyses looking into these applications often find, well, a similar picture.
Promising hints, but not definitive.
Exactly. Some studies might suggest a benefit, for instance, lower failure rates after meniscus repair surgery when PRP is added, but then maybe no significant difference in functional outcome scores. Or for low back pain or spinal fusion, some studies report pain reduction or maybe faster signs of bone healing on scans, but don't necessarily show that PRP improves the overall success rate of the fusion compared to standard methods. The evidence tends to be quite mixed, often based on smaller studies and hampered by that same issue of heterogeneity.
So really, outside of maybe knee OA, where there's a larger volume of research, albeit flawed, the evidence for PRP across the board is quite patchy and often low quality.
That's a fair summary of the current state, according to these reviews.
And what about those PRP-like products you mentioned earlier, ACS and APS?
Right. These are variations where the blood undergoes extra processing steps, aiming to perhaps enhance certain components, like anti-inflammatory factors in ACS, or concentrating a broader range of proteins in APS.
Is the evidence any clearer for them?
Actually, it's much less developed. The key finding from the sources is stark. There are currently no randomized controlled trials published specifically evaluating these PRP-like products. The studies that do exist are generally preliminary, small pilot studies with limited statistical power to draw firm conclusions.
So even less evidence to go on there compared to standard PRP.
Considerably less, yes.
Okay, that paints a rather complex picture for the blood-based therapies. Let's switch focus now to the other main category. The tissue and cell-based options like BMA, MFA, and MSC therapies. How does the evidence stack up for those?
Well, generally speaking, the development pathway for these therapies tends to be longer and more expensive than for blood products like PRP.
Makes sense. Dealing with tissues and cells seems more involved.
It is. And while safety data from initial studies often looks acceptable for several of these products, the overall volume of high-quality research, especially large RCTs and meta-analyses, is significantly lower than what we see for PRP.
And is the research focus similar, mainly knee OA?
Yes. Much of the existing clinical trial evidence for BMA, MST, and MSCs in orthopedics has also concentrated on knee osteoarthritis.
Are they plagued by the same issues of study quality and potential bias that affect the PRP literature?
Unfortunately, yes. The sources explicitly state that a high risk of bias is frequently identified in trials of cell and tissue-based therapies. This can sometimes be linked to factors like industry funding influencing study design or reporting, or simply due to poor methodological execution. It makes interpreting the results reliably quite challenging.
So, similar problems, just with less data overall. Can you give us some examples of the findings or lack thereof?
Let's stick with KOA, as it's the most researched area. One of the reviews cited a meta-analysis that specifically searched for large randomized controlled trials. They defined large as having over 100 participants in each treatment group, published between the years 2000 and 2023.
Okay, looking for the most robust evidence, what did they find?
Quite strikingly, they found only one trial focused on a cell-based therapy for OA that met their size criteria.
Yeah.
Just one in over 2 decades of research.
Wow, only one large RCT. Which therapy was that?
It was a trial investigating autologous adipose-derived MSC stem cells taken from the patient's own fat tissue, which were then expanded in culture, meaning grown to larger numbers in the lab, before being injected.
That really highlights the scarcity of large-scale evidence for these therapies compared to PRP, doesn't it?
It certainly does. And adding another layer of complexity, even that single large trial was assessed in the meta-analysis as having a high risk of bias.
Oh dear, why was that?
Issues were raised regarding how patients were allocated to the treatment groups and how the study handled missing data, which can introduce bias. When the meta-analysis pooled the data, primarily from this one large high-bias study, it concluded there was no superior effect on pain relief at 12 weeks compared to other interventions.
So the big picture from that analysis wasn't overwhelmingly positive.
Not from the pooled analysis, no. However, there's an important nuance mentioned in the source. The original publication of that specific large trial did report that significantly more patients treated with the expanded MSCs achieved what's called the minimal clinically important difference, or MCID, for both pain and function scores at the 6-month mark.
Meaning enough patients experienced a meaningful improvement at 6 months, even if the average difference wasn't significant at 12 weeks in the meta-analysis.
Exactly. It shows how different analysis approaches or time points can sometimes lead to different headline conclusions, which adds to the confusion.
That's a critical point. Was there any significant research published after that meta-analysis cutoff?
Yes, a very important one. A large, multi-center RCT with 480 patients was published in late 2023 by Mottner and colleagues, after the timeframe covered by the previously mentioned meta-analysis.
Okay, what did that one look at?
It directly compared intra-articular injections of BMAC and SVF stromal vascular fraction, which is another preparation derived from fat containing MSCs and other cells, but typically not culture expanded against the saline placebo injection for patients with knee OA.
A head-to-head comparison with placebo in a large trial?
Yeah.
That sounds like exactly the kind of study needed. What were the results?
The primary outcome was knee pain at 12 months, and the finding was quite clear. The study reported no superiority of either BMAC or SVF compared to the placebo injection. No statistically significant difference in pain improvement.
No difference compared to placebo in a large, well-conducted trial. That's quite significant, isn't it? It seems to temper some of the enthusiasm.
It certainly does. It represents a high-quality piece of evidence that challenges some of the positive findings reported in smaller, potentially less rigorous studies. It suggests that for knee OA pain, at least at 12 months, these specific preparations might not offer a benefit beyond a placebo effect.
So while smaller studies might hint at benefits, the bigger, better trials aren't consistently backing that up for cell or tissue therapies in KOA.
That seems to be the trend emerging from the high-level evidence landscape right now. Now, it's fair to say there are other smaller meta-analyses, often looking at trials with fewer than 30 patients per group.
Right.
Some of these have reported positive findings regarding safety and efficacy for therapies like ADMSCs, adipose-derived MSCs, or SVF. However, the sources caution that the criteria used to assess bias in these smaller reviews might be less strict, or many of the included studies themselves don't meet the criteria for low risk of bias across all important domains.
So again, the quality of the underlying evidence is a concern.
Yes. A recent 2024 meta-analysis pooled 15 RCTs on various cell therapies for OA, mostly small studies using VMSC-BME, ADMSC, or even umbilical cord MSCs. While its overall conclusion leaned towards safety and efficacy, it also noted that only about a third of the included studies were judged to have a low risk of bias.
So if you had to summarize the evidence for these cell and tissue therapies.
Based on the sources, the most studied are bone marrow-derived, BMSC-BMA, and adipose-derived, ADMS-CSVF products, mainly for EOA. They appeared generally safe in the context of these trials. However, the current high-level evidence from large, low-bias RCTs cannot definitively support clear mechanisms of action, leading to superior clinical outcomes compared to placebo or other treatments for many indications.
Right.
Therefore, the sources strongly emphasize the need for absolute transparency with patients about this limited high-level evidence when discussing these therapies as potential options.
That makes perfect sense. So we have this complex picture of variable evidence, further complicated by issues of standardization and study quality. And then layered on top of that is the regulatory situation, which sounds like another minefield altogether.
It absolutely is, particularly in the U.S., where the FDA, the Food and Drug Administration, is the main player. But it's not just them.
Who else is involved?
You've got the Federal Trade Commission, the FTC, which looks at advertising claims, making sure they aren't false or misleading. You have state medical boards overseeing how doctors practice. And then a whole host of professional societies and international groups issue guidelines or position statements, organizations like the APM&R, AMSSM, the
A
ISSCR.
lot of cooks in the kitchen, potentially. How does the FDA actually categorize these orthobiologics? Is there a specific system?
Yes, they have a framework specifically for what they term human cells, tissues, and cellular and tissue-based products, or HCTPs for short. It's outlined in Title 21 of the Code of Federal Regulations, Part 1271. Within that, there's essentially a tiered risk-based system. Tier 1 is the lowest risk, focused mainly on preventing disease transmission through good tissue practices. Tier 2 falls under Section 361 of the Public Health Service Act. These HCTPs need to meet specific criteria and require FDA registration and adherence to good tissue practices, but don't need pre-market approval.
In Tier 3.
Tier 3 is for higher-risk products, regulated under Section 351. These are treated much more like drugs or traditional biologics. They require an investigational new drug application, or IND, to even conduct clinical trials in humans. And before they can be marketed, they need a full biologics license application, or BLA, demonstrating safety and effectiveness. That's a very high bar.
A huge difference between Tier 2 and Tier 3, then. Where do common orthobiologics like PRP, BMAC, and MFAT2 typically fit?
This is where it gets particularly nuanced. PRP and PPP, platelet-poor plasma, derived solely from a patient's blood, are generally not regulated by the FDA under the HCTP framework as Section 361 products. They tend to fall under different, less stringent regulatory oversight focused on blood product safety and device clearance for the preparation kits.
So PRP has a relatively simpler regulatory path within this specific HCTP structure.
Compared to cell and tissue products, generally yes, regarding the HCTP rules specifically. Now, products like MFT and BMAC can potentially qualify as Section 361 HCTPs, avoiding the stringent 361 pathway, but only if they meet 4 key criteria.
4 criteria. What are they?
Okay, they are. 1, the product must be minimally manipulated, meaning processing doesn't alter its relevant biological characteristics. 2, it must be intended for homologous use only, meaning it performs the same basic function in the recipient as it did in the donor.
Right, like using bone graft for bone healing.
Exactly. 3, the product isn't combined with other articles, apart from water, crystalloids, or certain sterilizing agents. And 4, it either has no systemic effect and isn't dependent on the metabolic activity of living cells for its primary function, or it's for autologous use in a first or second degree relative or reproductive use.
That sounds quite specific and potentially open to interpretation.
Very much so. The interpretation of minimal manipulation and homologous use is precisely where a lot of the regulatory debate and enforcement actions have focused, especially concerning fat-derived products like MFAT or SVF. Does the processing significantly alter the tissue? Is injecting it into a joint for cartilage repair truly homologous to the fat's original function?
I see. And if a product doesn't meet all 4 criteria?
Then, according to the FDA guidance outlined in the sources, it generally defaults to being regulated as a Section 351 product, a drug or biologic, requiring that full IND and BLA approval process before marketing.
Which is a much longer and more expensive road. Is there any way around that, perhaps for treatments prepared and used immediately?
Yes. There's a critical exception known as the same surgical procedure exception, detailed in Section 1.71.15b of the regulations.
Same surgical procedure? Yep. What does that cover?
It applies when an HCTP, like bone marrow or fat tissue, is removed from a patient and implanted back into the same patient within the same single surgical procedure. The tissue must also remain in its original form and only be minimally manipulated as defined by the FDA.
Okay, so if a surgeon takes some bone marrow during a knee operation, spins it down minimally, and injects it back into the knee during that same operation, that might fall under this exception.
Precisely. If the criteria are met, this exception essentially supersedes the need to meet those four criteria for being a 361 product. It provides a regulatory pathway for many common autologous procedures.
But the definition of minimal manipulation is still key here, too.
Absolutely. And the FDA has issued guidance clarifying its interpretation. For example, using enzymes to digest fat tissue to isolate the stromal vascular fraction, SVF, is generally considered by the FDA to be more than minimal manipulation.
Ah, so that would likely push SVF outside of this exception and potentially into the 351 category, needing full drug approval.
That's the current FDA stance, yes. It's a really significant point of contention and regulatory focus.
The sources also mentioned some products being advertised that aren't actually legal for widespread use.
Yes, this is a major point of concern highlighted in the curriculum material. It warns practitioners and patients about products like many amniotic fluid or umbilical cord tissue products, culture-expanded stem cells where cells are grown in a lab to multiply, and exosomes.
What's the issue with them?
While these are areas of active research, they are frequently marketed directly to patients for various orthopedic conditions. However, according to the sources and current FDA enforcement, these products generally do not meet the criteria for Section 361 regulation and have not obtained the required BLA approval under Section 351 for these uses. Therefore, their marketing and use outside of an FDA-approved clinical trial under an IND is considered illegal.
So things people might see advertised online or in clinics might not actually be compliant with FDA regulations.
That's the stark warning. The FDA has particularly increased its enforcement actions against unapproved birth tissue products since 2021, making it clear they view most of these as 351 biologics requiring full approval.
That's a huge disconnect. It also brings up the terminology FDA cleared versus FDA approved. They aren't the same, are they?
Absolutely not, and it's a critical distinction. FDA cleared usually applies to medical devices, often through the 510(k) pathway. This means the device like a centrifuge or a kit used to prepare PRP or BMAC is deemed substantially equivalent to a device already legally on the market. It does not mean the FDA has evaluated the orthobiologic product itself for safety and effectiveness for specific clinical use.
Okay, so the kit might be cleared, but not the PRP itself for treating arthritis.
Exactly. FDA approved is the standard for drugs and biologics, like Section 351 HCTPs. This requires rigorous clinical trial data demonstrating safety and efficacy for a specific intended use or indication. And the sources are unequivocal on this point. Currently, no orthobiologic products or devices have received FDA approval specifically for treating osteoarthritis or tendinopathy.
That is such a crucial piece of information for patients and clinicians. So technically, using PRP for knee arthritis is considered off-label use.
Correct. Since PRP hasn't gone through the BLA process and received FDA approval specifically for the indication of knee osteoarthritis, using it for that purpose is off-label.
But off-label doesn't necessarily mean bad or experimental, does it? Doctors use medications off-label quite often.
That's true. The sources clarify that off-label use doesn't automatically imply a lack of supporting evidence, as we discussed. There is research on PRP for KOA, even with its limitations. However, it absolutely does mean the product hasn't met the FDA's highest bar for approval for that specific condition.
It's about the regulatory status, not necessarily the scientific underpinning, although the two are related.
Precisely. And this is where the FTC, the Federal Trade Commission, steps in regarding advertising. Clinics can't legally make claims that imply FDA approval for an unapproved use, nor can they make unsubstantiated claims about curing diseases.
Like broadly advertising stem cell cures.
Exactly. Using misleading terms like stem cells for products that aren't primarily stem cells or overstating the evidence can attract FTC attention. Violating FDA or FTC regulations can have serious consequences, including warning letters, injunctions, and penalties. It really underscores why staying informed about the evolving regulatory landscape is so vital for practitioners.
This complex web of evidence and regulation inevitably leads to significant ethical considerations, doesn't it?
Absolutely. Ethics and transparency are arguably even more critical in orthobiologics than in areas with well-established approved treatments, precisely because of the variability in regulatory nuances.
What are some of the key ethical challenges highlighted?
A major one revolves around nomenclature. particularly the pervasive misuse of the term stem cells. Patients hear stem cells and often equate it with powerful regenerative potential, maybe thinking of embryonic stem cells. But in orthobiologics, it's often used loosely to describe PRP, which contains no cells capable of differentiation, or BMSC in MIT.
Which do contain some mesenchymal stromal cells, or MSCs.
They do, yes.
Yeah.
MSCs are a type of adult multipotent stromal cell, sometimes referred to as medicinal signaling cells now. But BMSC and MFA contain a whole mixture of cell types, and the MSCs present are typically in very low concentrations compared to culture-expanded products, and they aren't being administered as a purified stem cell therapy in the way the term might imply.
So using that stem cell label broadly can create unrealistic expectations.
Definitely. It can significantly inflate patient hopes and misunderstandings about what's actually being administered and what it can realistically achieve based on current evidence. This relates to the broader problem of misleading public representations. Given the regulatory status, no FDA approval for common uses, and the variable evidence, some marketing practices can cross ethical lines. The curriculum source actually lists several tactics that might be used to give therapies an unearned air of legitimacy.
What sort of tactics should people be aware of?
They mention things like registering clinical trials, but then failing to publish the results, especially if they're negative. That creates a publication bias.
Right, you only see the positive studies.
Exactly. Also, publishing in predatory or low-impact journals that lack rigorous peer review, offering significant financial incentives for patients to pay cash up front, bypassing insurance scrutiny, using carefully selected patient testimonials or celebrity endorsements that aren't representative of typical outcomes.
And the misleading terminology we discussed.
Yes, using terms like stem cells inaccurately. Even things like forming seemingly official-sounding organizations that are essentially self-regulatory bodies without real oversight, or joining reputable academic societies, mainly for the implied credibility rather than active scientific contribution. These are all ways the appearance of legitimacy can be potentially manipulated.
It paints a picture where patients really need robust, honest guidance.
Absolutely. The cornerstone of ethical practice here is patient autonomy, which requires truly informed consent. That means having a detailed, transparent conversation covering everything.
What needs to be included in that conversation?
The practitioner must clearly explain the specific indication based on the best available evidence or lack thereof, the potential benefits and limitations as shown in research, the known risks of the procedure and the product, all reasonable alternative treatments, including standard non-surgical and surgical options, the costs involved, making it clear what is and isn't covered by insurance, and crucially, the FDA regulatory status explicitly stating that the product is not FDA approved for the condition being treated.
That's comprehensive. The cost aspect also raises questions about access, doesn't it?
It certainly does. Because these treatments are often not reimbursed by insurance, they are primarily accessible to those who can afford substantial out-of-pocket payments. This creates a significant potential for social inequity, where access is dictated more by wealth than by clinical need or evidence of potential benefit.
And conflicts of interest for the doctors themselves.
That's another potential ethical pitfall. Physicians or clinics might have financial ties to the companies making the orthobiologic kits, or their business model might rely heavily on these cash-based procedures. Such conflicts need to be transparently disclosed and carefully managed to ensure treatment recommendations are driven by patient best interests, not financial gain.
For a patient trying to cut through the hype and make a good decision, where can they turn for reliable information?
It is challenging, but good resources exist. The FDA website has information on regulated products and warnings about unapproved therapies, though it can be technical. The International Society for Stem Cell Research, ISSCR, has excellent patient-focused resources, particularly regarding what constitutes legitimate stem cell therapy. The National Institutes of Health, NIH, in the U.S., also provides reliable health information. Reputable patient advocacy groups for specific conditions might also offer guidance. Clinicians have an ethical duty to guide patients toward these credible sources.
So if we pull all these threads together, the variable evidence, the regulatory maze, the ethical considerations, they all point towards significant limitations and challenges still facing orthobiologics. What are the biggest hurdles summarized across the sources?
I think the first one has to be the inherent biological variability of the products themselves. As we've discussed, even using a patient's own blood or tissue doesn't guarantee a consistent product. Their age, health, genetics, even their immune profile. One source specifically mentions how immune cell counts influence PRP composition all play a role. It makes achieving a standardized dose incredibly difficult.
The patient is the variable, in a way.
In a significant way, yes. And then, layered on top of that, is the lack of standardization in everything else. Collection methods, processing protocols using different commercial kits, final preparation, dosing, administration techniques.
It seems like this lack of standardization is the root of so many other problems, particularly with comparing research.
It's absolutely fundamental. It directly contributes to inconsistent clinical outcomes and makes generating high-quality, comparable evidence incredibly challenging, which leads to the next major limitation: the relative scarcity of large-scale, high-quality, long-term clinical trials.
We need more big RCTs with low bias.
Precisely. Trials that use standardized, clearly reported protocols and follow patients long enough to truly assess effectiveness and safety. Without that robust evidence base, it's hard to gain widespread acceptance from the medical community, difficult for regulators to grant specific approvals, and almost impossible to secure consistent insurance coverage.
Which feeds directly into the cost issue.
Exactly. The high out-of-pocket cost is a major limitation for patient access, and the high cost of conducting the necessary large trials is a barrier for researchers and companies.
Are there other unresolved questions limiting progress?
Yes, quite a few scientific unknowns remain. What's the optimal dose of platelets, cells, or growth factors for different conditions? What's the best way to deliver them simple injection combined with a scaffold, slow-release formulation? Are combination therapies better? We don't have definitive answers yet.
And the underlying mechanisms aren't always fully mapped out either.
That's another key area. While we have good hypotheses about growth factors and cell signaling, the precise biological pathways, how these therapies interact with the complex environment of an injured or degenerating joint, and crucially, why some patients respond well and others don't. That's still not fully understood for many applications. Better mechanistic understanding could lead to much more targeted therapies.
And are there lingering safety concerns or potential downsides?
While the sources generally suggest serious adverse events are rare, with commonly used preparations like PRP and BMACM fat in clinical trials and practice, theoretical concerns exist. These include the potential for excessive scar tissue, fibrosis, unpredictable inflammatory reactions, or a concern primarily with cell-based therapies that might involve proliferation or differentiation, the theoretical risk of unwanted cell behavior, or even tumorigenicity if not properly controlled. These highlight the need for ongoing vigilance and long-term safety monitoring.
Okay, so there are clearly significant hurdles still to overcome, but the field isn't stagnant. Where is orthobiologics heading? What are the exciting future directions?
Despite the challenges, it's a very dynamic field. Several innovative approaches are being actively pursued. One area gaining a lot of traction is exosome-based therapies.
Exosomes. Tell us more.
Exosomes are tiny nanoparticles naturally released by cells. They act like little delivery packages, carrying proteins, lipids, and RNA from one cell to another, basically mediating intercellular communication. The idea is to harness these natural messengers, potentially loaded with regenerative cargo, to deliver therapeutic signals without needing to inject whole cells.
So cell-free therapy, using the message rather than the messenger.
That's the concept. They might offer advantages like lower immunogenicity, less chance of triggering an immune reaction, and perhaps reduce concerns about cells surviving or behaving unpredictably after injection. It's still early days, needing large trials, but it's a very promising cell-free approach.
Fascinating. What else is on the horizon?
Gene-based and mRNA-based strategies are also being explored. The aim here is to actually instruct the patient's own cells at the injury site to produce specific healing factors or to modify their behavior in beneficial ways.
Using things like CRISPR.
Potentially, yes. Technologies like CRISPR-Cas9 offer the possibility of precise gene editing related to cartilage or bone biology. Or using mRNA, similar to some vaccines, to temporarily make cells produce therapeutic proteins. These are definitely more futuristic, facing big challenges in terms of safe and effective delivery and ensuring the effects are controlled and durable. But the potential for programming tissue repair is immense.
It sounds like science fiction becoming science fact. Beyond these novel therapies, are there efforts to refine existing approaches?
Absolutely. A huge focus is on patient stratification, figuring out which patients are most likely to respond to which specific orthobiologic treatment.
Moving away from a one-size-fits-all approach.
Exactly. Researchers are hunting for biomarkers, maybe genetic markers, specific proteins or metabolites in blood or joint fluid, or particular patterns of immune cells that can predict treatment success. If we can identify responders beforehand, we can personalize treatment and improve overall success rates. That work on immune profiles influencing PRP is a step in this direction.
Personalized regenerative medicine, that seems key.
It does. And alongside that is the continued essential push for standardization. Developing and adopting clear, consistent, widely accepted protocols for how orthobiologics are prepared, characterized, and administered is seen as absolutely crucial for improving outcomes, enabling meaningful research comparisons, and ultimately achieving regulatory approvals and broader clinical adoption.
It seems like that has to happen for the field to truly mature.
It really does. We're also seeing more large-scale collaborative research efforts. The sources mention the European Proto Consortium, for example, which is bringing together multiple centers to rigorously investigate a specific placenta-derived cell therapy for knee OA. These kinds of structured multi-center collaborations are vital for generating high-quality evidence.
What about improvements in actually delivering the therapies to the target tissue?
Yes, that's another active area. Developing advanced delivery systems, like embedding the orthobiologic factors or cells within smart biomaterials, perhaps injectable hydrogels that solidify in place, or using nanoparticles to allow for slow, sustained release over time directly where needed. This could enhance efficacy and potentially reduce the number of treatments required.
And combining therapies?
Combination approaches are definitely being explored using multiple orthobiologics together or combining them with physical scaffolds, specific growth factors, or even traditional rehabilitation therapies to achieve a synergistic effect greater than any single component alone.
And technology like 3D printing fitting in?
Yes. 3D bioprinting holds promise for creating patient-specific scaffolds that mimic the structure of the tissue being repaired. These scaffolds could potentially be seeded with the patient's own cells or infused with growth factors before implantation, offering both structural support and biological stimulation. And overarching all of this is the potential role of artificial intelligence and machine learning to analyze large data sets, identify patterns, predict outcomes, and help tailor these increasingly complex treatments to individual patients.
So the future looks towards much more targeted, predictable, and personalized treatments, leveraging biology and technology together.
That's certainly the long-term vision, but, and it's a consistent message from the sources, getting there depends entirely on continued rigorous science, robust clinical trials, a commitment to standardization, and unwavering ethical practice. The potential is enormous, but there's still a lot of work to do to fully realize it.
Well, as we wrap up this deep dive, it's clear orthobiologics represent a really exciting frontier in musculoskeletal medicine, aiming to harness the body's own healing power.
Absolutely. But as we've explored, understanding this field means grappling with the different therapy types, the often complex and variable evidence base, the intricate regulatory landscape, and the very real limitations we currently face regarding standardization and predicting outcomes.
There's definitely a gap, isn't there, between the growing clinical use and enthusiasm and the still developing high-level evidence and clear guidelines, particularly once you move beyond the most studied areas like PRP for knee OA.
That gap is undeniable. The future looks bright with emerging technologies like exosomes and gene therapy and the push towards personalized medicine. But progress hinges on continued high-quality research, agreed-upon standards, and complete transparency with patients.
If you found this deep dive valuable, please do consider rating the show or sharing it with a colleague who might find it interesting.
And perhaps the final thought to leave you with is, could that convergence, better patient stratification, standardized combination therapies, advanced delivery systems, could that finally be the key to unlocking the full potential of orthobiologics, moving them from promising but variable options to truly predictable, personalized regenerative solutions?
A fascinating question, and one we'll surely be revisiting. Thank you for joining us on the deep dive.